All right, in the ER, we're used to the dramatic stuff, right? Trauma, bleeding. But some of the most critical situations are completely silent. They happen from the inside out. Today, we're going to dive deep into endocrine emergencies. These are the metabolic meltdowns that require you to be incredibly sharp and act fast.
You know, our training is all about seeing the problem, the wound, the break. But this right here is the whole point. The deadliest crises are often the ones you can't see. They're these silent, invisible collapses, a complete metabolic crash happening right at the cellular level.
So what are we really talking about? At their core, these are just massive hormonal imbalances. Think about it. When the systems that control your sugar, your thyroid, your stress hormones, when they just fail, your entire body starts to shut down. And the stakes, they couldn't be higher. Because these things can look like a dozen other illnesses. And if you miss the diagnosis, it can absolutely be fatal.
Okay, put yourself in the room. The alarms are screaming, your patient is crashing hard, they're completely unresponsive. Forget about hormones for a second. Forget about any specific diagnosis. What's the very first thing you do? Every single time.
It's always the ABCDEs. You secure that airway, you make sure they're breathing, you support their circulation, you check for neurological disability, and you expose them to find any hidden clues. This isn't just a checklist, it's the absolute bedrock of resuscitation. Why? Because you stabilize the human being first. Then, and only then, do you go hunting for the cause.
All right, first up, Diabetic Ketoacidosis, DKA. This is a big one. It's one of the most common endocrine emergencies we see, and it is a true, full-blown metabolic meltdown.
So what does this patient look like when they roll in? Well, the picture can be pretty dramatic. They're usually incredibly dehydrated, maybe vomiting, complaining about this terrible abdominal pain. But the real giveaway is the breathing. You'll see this deep, fast, almost sighing pattern. That's Kussmaul respiration. It's not just random. It's the body's desperate, last-ditch effort to blow off all that acid that's built up.
Okay, so to officially call it DKA, you need to hit 3 specific lab markers. It's a triad. First, their blood sugar is sky high. We're talking over 11. Second, their blood is acidic with a pH of 7.3 or lower. And third, they're full of ketones, blood ketones of 3 or more. You've got to have all 3 to lock in that diagnosis. It's non-negotiable.
Now, managing DKA is all about following a very precise 4-step dance. And the order matters a lot. First things first, you hit them with aggressive IV fluids. They're incredibly dehydrated. Next, you have to check their potassium and replace it if it's low. Then, and only then, do you start the insulin infusion. That's what shuts down the ketone factory. And finally, once the sugar starts to drop, you add a glucose infusion because you don't want to overshoot and make them hypoglycemic.
Okay, listen up, because this is probably the single most important safety step in this whole process. It cannot be overstated. You must check the potassium before you even think about starting insulin. Why? Because insulin shoves potassium from the blood into the cells. If their potassium is already low and you give insulin, you can literally stop their heart. You'll cause a fatal arrhythmia. So I'll say it again, fix the potassium first.
All right, let's flip the coin and look at the exact opposite problem, hypoglycemia. And let's be clear, this isn't just someone feeling a little shaky. A true sugar crash is a full-blown neurological emergency. It can look for all the world like a stroke or a major seizure.
This is the magic number you need to fear, less than 3.0. When the blood glucose drops below this, the brain is being starved of its only fuel source. It's like trying to run an engine with an empty tank. Every system starts to flicker and shut down.
Okay, so how do you fix it? Your treatment path splits based on one simple question. Is the patient conscious? If they're awake, alert, and can swallow safely, it's easy. Give them 15 grams of something sugary to eat or drink. But if they're out of it, confused, or totally unconscious, you can't put anything in their mouth. They need an immediate IV push of dextrose. And if you can't get an IV, glucagon in the muscle is your backup plan.
Okay, next up we're talking about the thyroid. This little gland can cause 2 completely polar opposite life or death emergencies. The best way to think about it is like your body's thermostat just completely breaking. It can either get stuck on full blast heat or it can get stuck on Arctic level cold. So let's look at these 2 extremes side by side. On one hand, you have Thyroid Storm. Think hot and fast. Everything is cranked up to 11. Sky-high fever, a heart that's racing out of control, extreme agitation, and dangerously high blood pressure. On the other hand, you've got Myxedema Coma. This is the cold and slow crisis. The patient is literally cold. Their heart rate is crawling, they're barely responsive, and their blood pressure has bottomed out. Your first job is just figuring out which one of these disasters you're looking at.
Managing a thyroid storm is like a military operation. You have to execute a very specific, carefully ordered blockade. First, you block the hormone's effects downstream with a beta blocker, like propranolol, that calms the heart down. Second, you shut down the factory that's making new hormone, using a drug like PTU. Third, you stop the release of the hormone that's already been made, using iodine. Fourth, you add steroids. And all the while, you're providing aggressive support, cooling them down, giving fluids. I have to say it again, the order is absolutely critical.
And speaking of order, here is the one detail you absolutely cannot get wrong. The drug that blocks the factory, PTU, must be given at least 1 hour before you give the iodine. If you mix that up, if you give the iodine first, you are literally giving the thyroid gland the raw fuel it needs to build more hormone and dump it into the system. You'll be throwing a giant can of gasoline right onto the fire.
Now for Myxedema Coma, the cold and slow crisis, the game plan is different. Step 1 is just supportive care. Get them warm, gently, and give them oxygen. Step 2, you give them back what they're missing, IV thyroid hormone, or T4. And step 3 is crucial. You give them steroids, like hydrocortisone, without waiting for labs. Why? Because a thyroid that has failed this badly often brings the adrenal glands down with it, and you have to cover for that possibility. Okay, our last case, adrenal crisis. This one is the great pretender. It's so often missed because it can look like so many other things. What's happening here is the body has completely run out of cortisol, its main stress hormone. If you remember one thing, one single phrase about adrenal crisis, I want it to be this. This is the patient in shock, whose blood pressure just will not come up. You can pour bag after bag of IV fluid into them, and nothing happens. That resistance, that refractory shock, that should be a giant, screaming alarm bell going off in your head.
So besides that stubborn shock, what other puzzle pieces should you be looking for? Well, the patient will be incredibly, profoundly weak. And then you look at the labs. They'll often have this classic trifecta: low blood sugar, low sodium, and high potassium. When you see that electrolyte pattern combined with refractory shock, you should be thinking adrenal crisis.
The treatment here is beautifully simple and incredibly life-saving. First, keep hammering them with IV fluids. But second, and this is the magic bullet, you give steroids immediately. A big 100 milligram shot of IV hydrocortisone. That's the key that unlocks everything. It replaces the missing cortisol, and suddenly their blood vessels can tighten up again and respond to the fluids. And third, of course, you treat their low sugar with IV dextrose.
Phew. Okay, we've just run through 5 really different but equally deadly emergencies. So let's pull it all together and boil it down to the essentials.
So here it is, all on one screen. For each crisis, you've got the one key feature you need to recognize and the very first thing you need to do. DKA, it's all about the acid and ketones. Hypoglycemia, look for the change in mental status. Thyroid crisis, it's either hot and fast or cold and slow. And adrenal crisis, it's that shock that just won't get better. Seriously, pause the video here if you need to. This is your go-to cheat sheet.
Look, these conditions don't give you second chances. They are absolutely unforgiving. But recognizing the patterns we've just talked about, that can literally be the difference between a patient living and a patient dying. You have the framework now. The final step is to actually think of these diagnoses when your patient isn't responding the way they should. You know the protocol. The question is, are you ready to lead? Subscribe for weekly 7-minute emergency medicine masterclasses. Learn to save lives, one case at a time.